Business leaders and executives, whether you realize it or not, your company and your employees are at risk. It's vital you know the hard truth about the current health insurance and healthcare system so you can discover what to do about it. The new book, Life and Death Decisions in the C-Suite, reveals how the private healthcare system and health insurance industry have plagued businesses and organizations across the U.S. for decades. What you learn from this book will open your eyes and help you take back control over out-of-control health insurance costs, resulting in massive savings for your company while also empowering you to provide better quality health care for your employees. Get your copy of Life and Death Decisions in the C-Suite now.
All right, welcome everyone today to our discussion, Life and Death Decisions in the C-Suite. I'm really excited for our conversation today. I am going to introduce Scott Cantrell, who is our MC for today, and let him take over in just a second. Scott, I've had the pleasure of working with for a few years now. He has been in the benefits industry and has served as a consultant to employee benefit advisors for more than 12 years now. He's recently worked with our Next Gen Benefits Network, which we are all a part of, and he has helped bring the Next Gen Benefit Advisor group together to publish this, what has now become already an Amazon best-selling book, Life and Death Decisions in the C-Suite, which is what we're here to talk about today. So Scott, welcome. Love for you to give us a little bit of background on the book and introduce our lineup for today.
Absolutely. Well, thank you, Katie. I appreciate the introduction, and thanks for all your fantastic work behind the scenes. I know it can be difficult pulling all these logistics together, but we do have a fantastic lineup for everyone today. And I want to welcome you and really congratulate you for investing your time and your attention today. Be sure that you are prepared to take notes. The other thing I want to mention is you should know that not only do we have organizational leaders and executives and C-level executives and business leaders from all across the country attending today, we also have other advisors and employee benefit brokers attending as well, all focused on looking to discover different solutions and strategies about employer-paid healthcare, the truth behind employer-paid healthcare, and how quality can be optimized while reducing costs at the same time. Katie mentioned I've had the privilege of working with this group of authors and the authors who contributed to and really did all the heavy lifting behind the book, Life and Death Decisions in the C-Suite. As Katie mentioned, it's already an Amazon bestseller. It's already sold several thousand copies across the country. The reason this book is so much in demand and has been, grabbed up by so many executives across the country is because it is focused on a key issue, one of the key challenges that we're facing today. As of this live presentation and recording, we are, fingers crossed on the tail end of a global pandemic. And it has really brought some of these healthcare questions to the fore. Not to say they were being ignored before, but now they're even more critical if you want to attract and retain and really build a productive and profitable workforce. You have to have a happy and healthy workforce. And that means that a workforce that has access to high quality healthcare. So Life and Death Decisions in the C-Suite really reveals how the private healthcare system and health insurance industry have plagued employers for decades. And it shows not only the problem and the challenges that you face as business leaders and executives, but what you can do about it, the specific solutions and strategies. And today, you're going to hear those solutions and strategies from a lot of the different authors of this book. So again, be sure you're ready to take notes. As you have questions throughout the presentation, we may or may not have time to do Q&A at the end. Obviously, a lot of your questions will get answered as we continue our discussion today, but be sure to use the Q&A box as it's available, a chat box, to enter in your questions. And if we don't get them answered for some reason during the session today, our team of advisors will be sure to follow up and make sure that your questions get answered. As we move into our keynote speaker today, I want to tell you a little about the origin of this book, because the origin of the book came from an event that was hosted by the Next Generation Benefits Network, where our keynote speaker was one of the featured presenters. And during her presentation, she used the phrase life and death decisions to describe the employer-paid healthcare system that we're all working within today. And she may talk a little bit more about that, but we're very honored and privileged to have this speaker with us. Deb Alt, AKA Nurse Deb, is the founder and president of Alt International Medical Management and a dear friend. Deb, great to have you with us today. She's been a registered nurse for 30 years. And before getting into care management, she did just about everything in healthcare, from bedside nursing and ER and ICU, working in doctor's offices, home health, and telephone triage. Now she is the president of AIM, Alt International Medical Management, and her team of nurses and doctors help patients navigate the health delivery and health insurance systems. And by ensuring that those patients, those right patients, are getting the right care at the right time, in the right place, at the right price, AIM creates situations where the patient, the provider, and the plan all win together. Deb, it's an honor again to have you here. I know that everyone's going to take tremendous value from your comments today. So welcome to the session today. Deborah Alt, everyone.
Well, good morning. Thank you so much for having me. I'm delighted to have the opportunity to share with you today. I've only got time, because we have such a great discussion plan, to do a couple of stories for you. The light bulb really came on for me many years ago when I decided to leave the bedside, that money was driving decisions about people's care. And what I came to realize as I immersed myself more in the financial side, on the insurance side of healthcare, is that there's really two major crises that are going on simultaneously in US healthcare. There is, of course, the cost of care consideration. We know that the cost of care has been escalating since the 1960s, and it has hit the point now where it's really unsustainable for the vast majority of employers who are really trying to do the right thing by loving on and taking care of their employees, by providing them what they intend to be a phenomenal benefit. How much more can you take care of somebody than to take care of them at the hardest time in their life, when they're going through a healthcare crisis? And by providing health insurance benefits for our employees, as employers, that's what we intend to do, to take excellent care of those that make our businesses run every day, all day long. The problem, though, is that there is a second crisis going on simultaneously, and it is a crisis pertaining to the quality of healthcare in the United States. We would like to think that as one of the best countries in the world, we've got the best healthcare in the world. And unfortunately, that simply is not true. Every other nation in the world that is on par with us from an economic standpoint has much better healthcare than we do. And we spend tremendously more than those other countries spend. So where is the disconnect? And I'd like to say that we have to almost stop viewing the crisis of healthcare in America as a systemic problem. We have to understand, and this is the point that I was driving home during the presentation that led to this book, this is an individual patient problem. A person becomes ill, or they have a health incident, or they have an accident, and they seek medical care. The care that they get in the fee-for-service system generates a claim. That claim turns into an insurance company. That becomes something that drives the premium that an employer spends for health insurance. There's a lot of idea behind keeping people healthy, and I love those ideas. And I think that we should all strive to be as healthy as possible, but inevitably, no matter how well we take care of ourselves, we all are going to eventually have some sort of a healthcare event or a healthcare crisis that forces us to access the healthcare system. And when that happens, we need to stack the deck in favor of the patient. So every June, a graduating class walks across the stage at a medical school, and they all get their degrees. Some of them graduate with a 4.0, some of them not so much. Wouldn't you like to know the quality of care that that particular physician is going to be delivering? By the way, they all get to put either MD or DO after their name. And we have now, through artificial intelligence, through technology, through claims data mining, through the CMS data system, access to information about the quality of care at different facilities and from different physicians. We even have evidence-based medicine that tells us what the right care is for an individual patient. So we know through the double-blind randomized clinical controlled study trials that are published enough about the majority of conditions that a patient will experience to know what is most likely to benefit that patient. Where is the cure for most of those patients going to come from? What procedures and services are going to improve the quality of life for that individual? Unfortunately, we don't mandate use of evidence-based medicine. Any physician can prescribe anything that that physician believes is in the best interest of that patient. And the day a physician graduates from medical school, he's over 7 years behind in current medical research. It's a real challenge and a real problem. And to compound things further, there is no single consumer reports of healthcare. So an individual patient can't simply get on Google and go, where's the best place for me to take my kid to get their tonsils out? Who's the best doctor at that? It's not as easy as buying a washing machine or a car, not to mention that we as American consumers often think that the highest quality must be the most expensive, right? If you're going to buy a Bentley, you know you're going to lay down some major cash. If you've only got cash for a Yugo, you know you've got to compromise on quality. The typical American consumer does not understand the inverse proportionality of quality and cost of care in the United States. Remember that fee-for-service system that I referenced earlier? Imagine this. You go in to have a simple scope surgery done on your knee and you contract an infection. You have to go back to the doctor to get that infection treated. Does that doctor get paid more or less when you have a complication? Well, in a fee-for-service system, they get paid more because they also get paid to treat the complication. Now, don't misinterpret. I am not in any way, shape, or form saying that my bedside brethren and sistren are giving you lesser level of care so that they can get paid more. That's not how that happens. But because of the fee-for-service system, the financial incentive of caring for a patient is not aligned with the outcome of that patient. In a fee-for-service system, the more services, the more procedures that are delivered, the more that practitioner or that provider, or more likely, since 74% of doctors' offices are now owned by health systems, the more money that health system gets paid. Seldom does the doctor, as an employee of the health system, get paid any more money, regardless of how many times he might see you. So the healthcare system works really well for two people. It works really well for the healthcare provider system, usually not the individual practitioners, though, the healthcare systems that own those practices. And it works really well for the insurance company. It simply does not work well for the patient or the employer who's providing the health insurance for that employee. I want to tell you a story about what prompted the life and death decisions. Many years ago, I was working for an employer, it happens to be a municipality, and the mayor of that organization had a very serious cancer. He had gone through many, many rounds of chemotherapy. One of the jobs of my company is to look at medical necessity and appropriateness of requested procedures and services, and to look at coverability by the health plan. And so we were doing that process. We got to the fourth type of chemotherapy, the fourth round of chemotherapy that they were proposing. And we gathered all of the information, and we were going through the medical necessity and appropriateness process, and we had some really serious concerns. See, this patient was having some major challenges with his liver function. Now, liver's not where his cancer was residing, but because of those challenges with liver, we got our physician to talk to his physician to ask multiple questions about how they had arrived at this particular chemotherapy regimen. And unfortunately, this was kind of a spaghetti against the wall situation. They had tried all of the traditional things, And now they were moving on to things that were kind of non-traditional in terms of treatment. And so our physician began to ask questions about the liver function and saying, we're really concerned with the proposed chemotherapy regimen. You see, this drug metabolizes through the liver. And if the liver's not functioning correctly, that drug will build up very quickly in the patient's body and could become toxic to that patient. He could actually overdose on a normal dosage of medication because his body's not able to process that drug correctly. As a result, we ended up denying that request for chemotherapy and saying, no, this is experimental investigational. In fact, we're very concerned that it could be dangerous for this patient. Now, these are real heartstring issues. Imagine being the director of the Human Resources Department or being on the County Board of Commissioners, and this beloved city figure who is struggling greatly with a diagnosis of cancer is now being told no to a requested treatment. Talk about gut-wrenching. However, the reason we were saying no was out of the concern for the safety of this particular patient. Because it was such a heartstrings issue, the group hired someone else from the outside to review that chemotherapy. And the nurse that they had review that chemotherapy said that she would approve that request if asked, because it was in the NCCN guidelines. Now, granted, I don't think she really dug deeply into the guidelines because the category in the guidelines that treatment was listed at really met the definition of experimental investigational. Further, I don't think she really looked at the patient's history or the patient's lab work because she never did address the multitude of studies that said that this chemotherapy was dangerous to administer to a patient who had compromised liver function. But because she had given it her stamp of approval, the group decided that they would override our decision and they would pay for that chemotherapy. As a result, the providers delivered that chemotherapy treatment. Unfortunately, 12 days later, that patient passed away as a direct result of the toxicity of the chemotherapy that had been administered to him. These kinds of things you might think are one-offs, that they are single horror stories, but they really are not. They happen every day, all day long. There are podcasts, there are movies, and we would like to think that these situations are the exception and not the norm, but unfortunately, that's simply not the case. Of course, there are many success stories, and we're always happy to tell about those. But executives who are purchasing health insurance benefits for their employees, it's time for us all to come to realize that we are really looking at the health and welfare and well-being of an individual who has become ill, who is frail, who is fragile, who is emotional, and they rely on that health insurance benefit to look out for their best interest. Now, do you think the big insurance carriers, if little old me, Nurse Deb in Columbus, Ohio, has access to evidence-based clinical criteria, quality scores of different providers, do you think that perhaps the big old insurance carriers have them? Yes, absolutely. They have access to them, probably had access to them long before I did. Unfortunately, the contracts that they strike with those health systems and providers often prohibit them from being able to share that quality data with a patient. They're prohibited from doing what we in the industry call steerage or guidance or navigation with an individual patient. I'm here to tell you as an employer myself that it literally scares me that one of my key employees might become ill and need healthcare and not have access to what the gold standard of care is and who the top-notch providers of delivering that care are. And that's a crisis that those gathered in writing this book have overcome. The solution does exist. It is out here in the marketplace. It's functioning very well. And by the way, in that fee-for-service system, the opposite is also true. Healthier people file fewer claims. So if we get our people as healthy as possible, as quickly as possible, by getting them the best possible care from the best possible providers, that care will inevitably be less expensive. The lowest price will become the natural consequence of getting our people everything that they need and getting it done by those providers who are able to get them healthy quickly. So the solution exists. Meet up with one of the fine folks that are on this call. They'll be happy to tell you more about it. And anytime you have any question or anything that we as the nurses that are part of your health plan can help with, we'll be more than happy to do so. Scott, back to you.
Deb, phenomenal insight as always, and I trust everyone was making notes and listening very carefully to what Deb was saying. Just this one realization that's a very common misconception, as Deb pointed out, this inverse proportionality of quality versus cost. And the reality is that expensive care rarely equals the highest quality care, is a huge paradigm shift in our country. And it's critical for executives and decision makers, like all of us are, to realize that, and then to make sure that our actions that we take are in support of what the reality is. So Deb, thank you so much. Deb, I want to keep you on, and I want to bring in our other panelists here, our other expert panelists, who are all significant contributors to the book, Life and Death Decisions in the C-Suite. And you all should know that each one of these individuals have real world knowledge, real world skill, experience, expertise in working with companies and organizations to adopt this new approach, this new next generation model of delivering employer paid and meaningful quality, access to quality healthcare to their employees. So let's bring on all of our panelists. Our panelists can go ahead and turn on their videos and unmute yourselves, and we'll just keep the discussion going here. Again, for those of you who are in our audience, if you have questions, go ahead and put them in the Q&A box, go ahead and put them in the chat box. We'll try to monitor that in real time here. But if for some reason we don't get your question answered, we'll be sure and follow up after the fact. We'll just kind of go around and we'll keep it open to everyone. So if you have something to chime in with, please do. I want to begin by asking the first question to Ben Connor. Ben is the CEO of Connor Insurance based in Indianapolis. He's also a 2020 Broker of the Year finalist and a sought after speaker and presenter throughout the industry. Ben, I wanted to talk with you about your own experience and where should employers and decision makers really begin to address these life or death issues? Where does this begin? Where's the starting point for everyone?
Yeah, I think, Scott, thanks for the question. And Deb, thanks for the intro and the explanation of why this is so powerful and impactful. But I think when we look at where employers need to begin, it's kind of the outgrowth of an employer's culture and the leadership within that organization. In the book, I talk about kind of my journey as a leader and how getting off on the wrong foot ended up to be challenging for us as a business, and how we really had to do the hard work of redirecting ourselves and establishing a culture that really allowed everything else. And when it comes to this approach about translating that to a healthcare program and caring for your employees, every employer is going to do that in their own unique and specific ways. And I don't think you can really get going until you know the way in which you're going to do that, because your employees will expect that leadership that you've established with them and within your culture to carry over into everything that you do, including the healthcare program and your approach to compensation and benefits.
Oh, that's phenomenal. And it makes perfect sense that obviously these types of strategies and tactics that have to be implemented have to begin at the top, and it is driven by the culture of a given organization. Makes sense. I want to turn to Randy and Nick Hansen, a father and son team out of the Seattle area. They are leaders of a firm called PSG Washington. Nick, for you first, going back to this idea of quality and quality scores of providers. Tell us a little bit about your own experience with those quality scores in the real world.
Well, luckily for us, we haven't had anything as dire as Deb's story. But definitely, I could go on all day about situations where we found something. Recent one we just did was we have a large clinic in our area, probably, 500 or 600 doctors owned by one of the healthcare systems like Deb was talking about. And we had an individual who was going to go in for surgery there and did all the right things. He knew that, one of the things AIM does for our plans, they're also on the pre-certification side. So he knew if I call in to get it pre-certified, it's going to move faster if I do it. I can get the quality scores from him. So he does all that, calls AIM, and nurse looks up the score of the surgeon. It's a 14 out of 100. Now, that is not good. We don't want you going to that person. So one of the concerns a lot of people have is, well, if I go to a different surgeon, am I going to have to drive 60 miles away to do it? In this situation, we looked it up. There was a surgeon probably in the office next door to this guy that was a 93 out of 100. So not only were we able to keep the date of the surgery, we kept it at the same facility, the same, outpatient care, everything for this guy. And, he's happy. We're happy because we know we've got high quality provider taking care of this guy, less likely for readmission, infections, that kind of thing. So like I said, I could tell you stories like that all day long, but just know it's not just, one hospital is good, one hospital is bad. There's actually these high and low score surgeons and doctors intermingling shoulder to shoulder inside these facilities. Yeah. And that's kind of scary to us too, is you don't know, right? You're just getting referred through the system. His doctor said, here's a great surgeon, you're going to like him, whatever. And he had no idea.
Yeah. It is what you're saying, I think, is critically important. And Deb, you alluded to this a second ago, where you're talking about it's not like buying a washing machine or buying a car. And how ironic is it that the average American consumer, it's not their fault, they're not empowered to do so, but the average American consumer will spend hours and hours and hours researching, what kind of TV they want to hang on their wall or what kind of car they want to drive. But when it comes to their health, arguably the most important thing in their lives, their own health or the health of a loved one, it's simply whatever the person said, or whatever, you should go see this person, and there's no double check, there's no check. Maybe the recommendation that was given to them was exactly correct, but that's the point. We don't know. The consumers simply don't know. And so, Deb, to that end, let's talk about the types of employers and organizations that are best suited to embrace these types of strategies. Does this work for everybody? What kind of organizational leaders should be saying, I need to do this today?
Yeah, absolutely. One thing that we have to understand is, in a void of actual facts, other things will fill in. And a great marketing budget does not mean a facility is phenomenal. We see it over and over and over again. So the place that has the most billboards has a great marketing budget. It does not mean that they are phenomenal at delivering the type of care that you as an individual need. So that's a huge challenge to overcome in American healthcare. And to Nick's point, I get in a little bit of trouble because I tend to be a little rowdy. And I tell people all the time, yeah, he looks like a real Casanova. If you want to date him, go ahead. But for the love of God, don't let him cut on you, right? Just because he's nice doesn't mean he has a good quality of care. But the type of employers was your question. And I will tell you that it is possible for any employer, meaning somebody who has at least one employee, to embrace these kinds of solutions. There are some employers that it's not a great fit for. I will tell you that employers come to me all the time focused 100% on, hey, this is my third largest expenditure on my P&L, and I've got to cut it in half, and money, 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 money. And those types of employers will be successful, but for a very short term, right? You can only take so much spend out of healthcare. People are going to get sick. And if you're focused 100% on the money, it's not going to be a great solution. If, on the other hand, you really love your people enough to say no when it is in their best interest, when that care is fraudulent, wasteful, abusive, If you love them enough to say, time out, pause, I know you're scheduled for surgery, but were you aware of this surgeon's quality score? And do you maybe want the inconvenience or the disruption or the noise of saying, here's vital information that you wouldn't normally have access to. It's something you need to consider. If you can wrap your head around the fact that if you really love your teenager, you're not going to hand them the car keys to the Lamborghini and let them go out, unchecked. We have to begin to adopt some of that attitude with our own employees. Even though they're adults, they have free will. But if we really love our employees, and if we really want to retain them in today's market, we're going to have to love them enough to tell them the difficult things, to have the tough conversations.
Well,
Yep.
Deb, I think to that point, I think employers need to have the mentality of being a teacher, a coach, or even a protector. And you see a lot of things, especially around the Great Resignation, where, people are looking to attach themselves to strong leaders. Mm-hmm. And, that's what this concept is all about, because we're talking about something that's very personal. And Deb, as we talk about, even you and me, healthcare, as much as we can give the facts, ultimately it's emotional. But that doesn't replace the need for the facts and giving our workforce the information they need to make those really good decisions and coach them through that of the why. I think it's just really important for employers to want to be teachers rather than just going through, unfortunately, the process that we've all been taught over the last however many years of how you run a health insurance plan. It's more than that at this point. We're talking about true healthcare.
Right. It's a great point, Ben. And if you think about being a business leader and executive, let's say you're running a manufacturing plant. I know nothing about manufacturing, but I know that it's hard work, and I know that it's labor intensive, and it's critical that certain people do certain things in a certain way correctly. You would not put an employer on the line without properly training and empowering them to do the best quality work to protect themselves and to get the optimal result for the organization. Yet that's absolutely not the case when it comes to the healthcare system. So it's a little bit ironic. And look, the reality is the status quo has been so pervasive across our country and throughout the business community that this has purposefully, in some cases, business leaders have been kept away from the truth about what's actually happening. We can talk about the whys and the wherefores and the incentives and the motivators behind that. But the reality is now today that there, thanks to people like you all and books like Life and Death Decisions in the C-suite, this paradigm is starting to shift and eyes are starting to be opened in terms of what is actually happening and how it can be corrected. I want to go to Ryan Spencer, also from Connor Insurance there in Indianapolis. Ryan, in the book, you wrote a chapter sort of breaking this down tactically into thinking about employer paid healthcare through a phrase that you refer to as healthcare supply chain management. And I think this is the right way for a business leader to really start to how they should think about how healthcare gets delivered to their employees. Can you sort of break that down for us and walk us through that process?
Sure. Thanks, Scott. As Nurse Deb mentioned, this is a very individual process, right? People are managing or walking their way through physicians and the quality component. But if we step back, how do we manage this? And we have to really manage it at a higher level. And this is where the concept of the supply chain comes in, right? And you compared it to a manufacturer. My background's in engineering. I worked at a manufacturer for a little while, and it was an auto manufacturer. And so if you look at a supply chain like that, right, you have an engine and wheels and a chassis and all of these pieces that come together to create a final product. Yeah. If we look and compare this to healthcare, it's not a whole lot different. You have a bill payer, you have physicians and facilities and pharmacy and some different strategic partners that you put in place of your healthcare, and to really provide visibility of that and manage each of those components can really impact your cost as well as the quality, which is what we're here to talk about today.
Yeah, well, I think it's a great point. And again, employers of all shapes and sizes, whether it be an automotive manufacturing company or some sort of service provider, there is a supply chain. And we are very closely aligned with that supply chain. We pay attention to it very, very closely because that determines the level of quality that we're able to deliver as a business to our clients, to our patients, to our customers. At the same time, when it comes to healthcare, most business leaders don't think about the product and the quality level of healthcare. They think it just happens over here, and we provide access to it, and that's where it stops. But if we start to think about this from a healthcare supply chain standpoint, to your point, Ryan, we are able to pay closer attention to the quality in real time at these different points along that healthcare supply chain process.
Right. There's parallels, right? So in manufacturing world, there's recalls and there's warranty and there's different things like that, right? And in healthcare, it looks a little bit different where you have follow-up complications and surgeries and some of those things, but it's, there are certainly parallels between, a manufacturing supply chain as well as the healthcare supply chain. And there are different ways that you can jump in and manage it. So,
yeah. I want to bounce to Griffin Meredith and then to Randy Hansen. We'll continue our conversation here. I trust that everyone is paying close attention. And again, you've got to be taking away meaningful value. I know that you are. Griffin is the leader of Commonwealth Insurance Partners out of Louisville, Kentucky. Griffin, in your chapter, you talk about the specific term, the word relative, when referring to the risk in the health insurance space. Can you talk a little about that, how a business leader should think about the relative risk that they're facing around healthcare and health insurance?
Sure. Thanks, Scott. The reason that I thought this was the most important piece to start with is because a certain percentage of people that you talk to just hear the term self-funding, self-insurance, and automatically freeze up. Yeah. There's an understanding that, oh my goodness, that sounds more risky. And that's simply not the case. We're not sending you out there, uninsured. You're still backing this up with something that ultimately protects you from catastrophic risk. So, I think, and something as I've been listening to people talk, I think to bring it home for many people out there listening is just, this is the modernization of healthcare financing. As many things before this have been modernized. If you think about, middlemen that, provide a product or service that was difficult to understand or, maybe didn't have transparent business practices in the past, with big margins built in, they were addressed, and I think that, a couple of examples of that are, whenever you think about like in-house counsels at, companies out there, they got tired of paying rack rate for, legal services. So they're like, well, how can I address that? Or you go back to a time before the internet. I think that, you had people using group purchasing organizations, and, these were things they understood, like, okay, that, now I'm, purchasing out of a catalog, blindly at some of the things I do with larger some of the larger things I use every day. And ultimately, individually shopping those larger items was a better concept. So this isn't to, overcomplicate, each detail of your business. But, when something reaches a critical mass, as in the price of healthcare, it takes a little more oversight. So I think what we're trying to get across is, this is typically your second or third largest line item. And you're typically outsourcing it to someone who has very little detail that they're giving you as to what things cost. So, I just wanted to make sure that, we're talking about that basic economic principles and normal business practices do apply here. So I want to tie that in because risk is relative. We understand risk of walking across the street. We understand risk of buying fuel right now for a, Boeing or, the companies that, airliners that, buy it early because they think that the price is going up. You can conceptualize that risk, but when you hear self-funding, a lot of times you're like, oh no, a hospital stay, I'm done. And that's not reality. So I think it's just to keep things in perspective, understand that in reality, you're still hedging against catastrophic loss. Yeah. So I think that's conceptually what we want to drive home is don't be scared. Listen to it, understand that what we're trying to, address is not the $1 million claim for the baby that was 9 weeks early. Our goal is to manage everything from day one that can be managed in a much more efficient manner than completely outsourcing it to someone else.
Yeah.
Like getting that mom who's pregnant and high risk to the best high risk OBGYN. Maybe instead of 9 weeks, that baby can be born at 4 weeks premature, which more than quadruples the likelihood of their survival and greatly diminishes lifelong complications.
Yeah.
I mean, I feel like we've had this sort of, in our world, we've had this transition, a progression, if you will, where we address the biggest things first. 4 or 5 years ago, we were talking about price gouging, transparency, make people aware. And now as we've started to make that more common knowledge, if you will, that there is a difference in pricing, now the education piece becomes the items that Deb's talking about. Who doesn't have a story? And we don't have a show of hands option, but who doesn't have a story about my mother had this circumstance happen? My mother-in-law this weekend at our child's birthday said that she thinks the hospital killed her mom. That's, I'm not trying to be over dramatic here, but that was her way of relating the healthcare system to something that happened 30 years ago. So everyone has a story, Deb. Everyone has an interaction with the healthcare system where it was like, wow, that was not the way it was supposed to go. But we don't cumulatively put all those stories together for one message that, hey, let's pay attention to this.
I think that's a really important point, Griffin, right? And there are lobbies and organizations out there that don't want these stories that you all are telling to be public in any shape, form, or fashion. And the reality is, going back to something that Deb said during her presentation, these types of stories are not one-offs. Now, healthcare has its fair share of successes too, and we should celebrate those, rightfully so. But at the same time, this is not about taking aim at a particular doctor or a particular situation. It's about looking at this systemic. It's about looking at this as a whole and understanding that the system is filled with misaligned incentive that is creating a perpetuation of lower quality healthcare for rising costs. And the two things go hand in hand, unfortunately. So we can shift that paradigm and focus on quality first. That will inevitably, as Deb said, create a race to lower pricing. Griffin, you talked about everybody's got a story, and I want to bring in Randy Hansen here, who has a incredibly impactful story. Randy, I'd love for you to touch on that, share any other insights or thoughts that you have related to the discussion here. But I know you've had some personal experiences, and no doubt those of you out there watching this presentation would be able to relate to a lot of these stories too. What we're trying to do is not only open your eyes to the fact that these are not one-offs, but open your eyes to the fact that these things often can be prevented when the proper process is in place. And that's to the benefit of everyone when that happens. Randy?
Yeah, thank you, Scott. I guess I'm at the age now where I've seen so many one-offs that it's actually keeping me working. That I probably should retire a long time ago, and I just have this commitment now that I have to help keep fixing the system. And my chapter, I'm not going to spend a whole lot of time in the chapter. There's people that are online, you can read that chapter, but did have a situation with my mother. She's still alive, thankfully. She's a tough old Norwegian, and she's 88, but the situation with her is a situation that, quite frankly, I'll take to my grave with me. There was mistakes made, and they shouldn't have been made, but rather than spending time on that, if you don't mind, I'd really like to touch back. Deb mentioned fraudulent, wasteful, and abusive situations. And we just had one recently that when she said that, I just went, oh my goodness, we got to talk about this. Nick and I have a client that's about 1,000 life client, and they're in multiple states. And right now they're in the buying mode, and they had bought another location, and it was coming online January 1. And one of their employees phoned our office about mid-December and said, I'm in the middle of chemotherapy, and my next chemo treatment is January 4th. and I need to have it done January 4th for obvious reasons. And is there any way I can get this thing pre-authorized? And we use Nurse Deb services, and there just wasn't enough time to do a full pre-authorization on this. So we went ahead and pre-authorized it without any medical review, that first one. We'll take care of this one, young lady, and but we will have to go through the pre-authorization service for the next treatment. And through the pre-authorization service, Nurse Melissa there noticed that it appeared that maybe the drugs they were using in this chemotherapy did not fit the diagnosis. So it either doesn't fit or it's experimental, and the plans don't cover experimental. So we came back to the doctor's office and said, look, we don't pay for experimental, and we'd be happy to do a peer-to-peer with your doctor, one of Nurse Deb's doctors with that physician, to decide the appropriate treatment. Doctor's office said, put that on hold, we'll get back to you. 2 hours later, the doctor's office called AIM and said, forget that procedure and that chemotherapy. We're changing it because we had the wrong chemotherapy. Wow. And Nurse Melissa said, so did you give that drug to the patient? And they said, yes, twice. And so through this process, we talk about money all the time, but through this process, we may, I don't know, but we may have saved this young lady's life, because Nurse Deb and her group pointed out to the doctor that it was the wrong therapy for this woman. So they changed it right away. Doctor's office very kindly said, oh, by the way, we're not going to charge you for that treatment, right? We started looking at the treatment though, and this is where the abuse comes in. We started looking at the treatment. The chemo drug that we can get white bagged, we can provide it to that office. Exactly, it's the chemo drug that they want to use. $6,500. Doctor was charging $24,000. The anti-nausea drug that they were using, we can white bag that for $350. It's the same drug. There's no change there. Same manufacturer, everything. We can provide the doctor's office with that. The doctor's office was charging $14,000 for that. There were 4 different drugs that went through that sort of a process that, the prior carrier, who was a large, very identifiable national carrier, had rubber stamped that. Nobody had ever even looked to, number one, see if it was the right treatment. Number 2, to see what the costs are. So as you're on this fully insured plan and you get this renewal, and it's a 15% renewal, and your agent says, boy, look at the claims. Claims are claims, and that's why your rate is going up. Well, if you're paying $24,000 for a $6,000 drug, and you're paying $14,000 for a $350 drug, then you probably deserve a rate increase. We have got to stop rubber stamping these things, and not only for the safety of the patients, but because we're in an environment right now where employees can't cover their dependents, their kids, because they just can't afford it. And at my age, that is just heartbreaking. We have to do something, and the C-suite has to do something to change that so that we make this affordable again. And it really is a controllable cost, Scott.
Yeah. Yeah, it's great insight, Randy, and thank you for sharing these real world examples. And all of you, thank you for sharing your real world examples, because these are the stories that all of us as business leaders and executives need to hear. We have to hear to understand what the alternative is to the status quo. And until we see the alternative, we understand the alternative, and we see it in action producing results that we want to get, we're going to have tendency to stay where we are. But when we start to understand the results and outcomes that can be created through strategies that, to use a healthcare term, are largely non-invasive, why would we not shift? And I think that's the question for a lot of executives across the country. To that end, Deb, for an employer that decides to take a stance on this issue, they understand the status quo is unsustainable. from a cost standpoint, certainly, but it's just not good from a quality standpoint. Like you said, if you really care about your workforce and your employees, what types of outcomes can an employer or a workforce or an employee population expect? And maybe what are some next steps to make that happen?
Yeah, that's a great thought. I think that people have to understand that anytime you make a change, especially one that's such a big paradigm shift, that you're going to have to put some work into it, right? There's a massive education campaign that goes to your employees to get them to understand why you're doing this, right? To have these kinds of discussions with them preemptively. Right. That yes, we're leaving the big Blue Cross, United, Cigna, and Humana, whatever carrier name is on your insurance ID card currently today, and here's why. And here's what we expect the outcome to be. And you've got to have a process for that transition. Like Randy said, this woman was in the middle of chemotherapy. She'd already gotten chemotherapy and she needed to continue to get chemotherapy. So you have to have a plan and you have to have communication with your employees. I often will tell new customers, listen, if there's not people showing up in HR asking questions, what is this? Why is this going on in those first 3 months? Then I have probably failed miserably, because anything new or different, no matter how well you communicate it, when somebody experiences it, they're still going to have questions. Sure. So you have to kind of, as an employer, go into it knowing that you actually want some noise in the beginning, that if we're making this big of a change, people are going to have questions, right? There's going to be dialogue that happens. The other thing that I would say is that it's unfair of us, even though we're immersed in the industry, to think that your average employer who spends their day focusing on insert here, widgets or service in a hotel or auto dealerships, right? If that's their focus, you cannot expect them to become experts in healthcare and in health insurance. So they're going to have to engage someone who has that expertise, that has spent the last several years honing and refining and understanding and diving deeply into the issue. And they're going to have to find someone to not only bring that expertise, but who is aligned with them, right? Whose motivations and whose compensation are aligned with them as the employer sponsoring the health plan. And that really is critical, because you want somebody who is up at night worried about it right alongside you, and somebody that you can trust. So when they come back to you and say, hey, this person's going to show up in human resources, we're disrupting their chemotherapy because the treatment that they're giving is not the right treatment. We're not just rubber stamping it and giving them an automatic authorization because we're worried about this, right? That they are comfortable with and understand that, and that they can support that and understand that in the end, that is a good thing. But there will be some noise. And so they have to be prepared for that. And they have to pick an ally that is going to be on their side of the table.
100%. And I think that, yeah, go ahead, Griffin, please.
Well, Scott, I was just going to interject that we've mentioned several things about like chemo and these big ticket items and all these things that are just, maybe pie in the sky to someone. And that's not all that it is. We had one not within the last 2 weeks, that was a newly diagnosed diabetic who was going to get an insulin treatment. And whenever the insulin was prescribed, the PBM kicked it out. Deb's team looked at it and was like, well, hold on. The doctor's notes say right here that this patient is allergic to this medication. So it was like the doctor was prescribing. And again, it's similar to Randy's story where they popped it out and said, hold on, the physician looked at it. 2 hours later, it was resolved. The physician was like, yeah, that you're correct. There needs to be, a different, regimen. And it was that quick. And this was something as simple as a diabetic, which comes up very frequently now. So I just wanted to paint a quick picture that it's not always these crazy items. And, there was the Mayo study, and you all can Google this, that talked about 88% of all Mayo treatments were either, changed, or it was not the original treatment that was done. That's nearly 9 in 10 circumstances where a second opinion from a reputable place said, pump the brakes, let's review this. So I think having, medical management like Deb's team in the middle of the circumstance just gives you a second set of eyes that truly let you manage differently.
Well,
And I just want
Griffin, I think you said it beautifully earlier when you talked about the modernization of healthcare. We've modernized when we live in the age of information. You just said you can Google this, and healthcare in and of itself is stuck with one brain in the mind of a surgeon or physician. And how dare we question that? And that on its face is absurd that we would still operate that way. Deb, going back to your statistics of someone graduating school 7 years behind, because information is happening so quickly and studies are happening so quickly. So we simply need to modernize the approach of healthcare so that we're not putting our employees in harm's way.
Yeah. Well, and let's talk about that. We've got just a few more minutes here. I want to touch on a couple more things. Ryan, you talked about the healthcare supply chain process. Just for people who are starting to adopt this paradigm or starting to think through things in this way, what are some of the key issues in the healthcare supply chain that can cause the most damage?
Yeah, I would say if I were to list just a few of them, obviously the quality of the physician. When we talked about, we just had 3 or 4 case studies of that, right? If you prescribe the wrong medication, just think about the implications that can have via cost, as well as just that impact on that person's life. I would say that, so quality of the physician, I would say having a provider or a carrier that will just approve everything, right? Not having that oversight, right? So those kind of tie hand in hand. And then you have cost of facilities and the high cost of specialty pharmacy in your plan, right? Those are ones that can really drive and cripple, if we're talking budget, and as well as some quality issues. I would say those items are ones to really keep your antenna up on as you look at the things going on in your plan.
So to that end, one of the notes that was just made a second ago by Deb and everybody has alluded to it is the fact that you don't need to try to do this alone, right? You need to have the right partner, the right ally was the word that was used, which I think is exactly right. The right ally, the right advisor coming alongside you to make sure that you're at least asking the right questions. At the end of the day, it's about knowing what questions to ask to shift the status quo into this next gen model. And, Ben, what you were talking about and what Griffin was alluding to, the reality is the world is evolving much, much more quickly than the healthcare delivery system and the health insurance delivery system, right? Medical advances, like you mentioned, Deb, and was pointed out again, medical advances are going really, really fast. But if a doctor doesn't know about them, then that's not useful from that standpoint of working with that particular doctor, which is why the value of having more brains as opposed to depending on one, especially if they have a low quality score, that can be very, very difficult and very, very risky. Ben, I want to come back to you for a second. At the end of the day, you all have talked about in very practical and tactical ways, this idea of how to move out of the status quo of healthcare delivery for employees into a next generation, a new model that can deliver better access to better quality healthcare for the employee. And therefore, because of this inverse proportionality, the inevitable result is lower cost for the employee and the employer. Your chapter is about mission-driven benefits. Kind of going back to one of the first things that you said. At the end of the day, the organization's got to lead the way. The leadership has to lead the way. The culture determines the actions that are taken. How do you think that approach, what would you say to an executive who is saying, I get it, I understand it, and my culture demands that I execute? How does this idea of mission-driven benefits, which is the chapter in the book, become execution and results?
Sure. So in every area, business leaders are very intentional, or usually are very intentional in their approach. With healthcare, that intentionality is non-existent. In fact, we use the concept of, I hope my renewal is okay. I hope these things are happening. And in no other fashion, one is hope a business strategy, but they certainly don't put any of their other business units in that category. So it's ultimately one, about building the right team. We've talked about that, not only internally, but with the right partner. But then we talk about adopting, and this is what I love about this collection of authors, is it's adopting a process that is not about activity, but is about results.
Yeah.
And we're not just talking about financial results. And Deb even mentioned financial results are just the outcome of doing the appropriate things, but it's the process of addressing really where the key issues lie, and doing activities that actually drive outcomes, and then measuring that to see where improvements can be made. Because do we just have like the easy button or the magic thing that works? And the answer to that is no, because there's a lot of variables at play. Specifically, we have a team here from the state of Washington and from Kentucky and from Ohio and from Indiana. And Scott, you're in Nashville. So we all have locational differences with different hospital facilities and that sort of thing. So plans are inevitably going to be different, but the process of addressing the core and root issues is similar. And we have a proven strategy of how we approach that and then how we measure the outcomes. And employers have to do that. They do that in every other area of their business. This should be no different.